Slide 1. This is one of a series of slide tapes on renal pathophysiology prepared by the American Physiological Society. 2. Before you go any further, make sure you have completed the prerequisite test provided in the study guide that accompanies this unit. 3. Question slides will appear at intervals. Stop the tape to answer the questions. Then advance to the next slide on which the correct answers will appear. Stop the tape again to check your answer. After you finish the unit, assess your understanding of the material by taking the post-test in the study guide. 4. This unit will discuss disorders of potassium balance. Content expert, Dr. Fred S. Wright. 5. We will review normal potassium balance. Then we will discuss abnormal plasma values due to 1. Artifacts, and 2. Shift of potassium into and out of the extracellular fluid. We will also discuss high and low plasma potassium and other clinical manifestations of abnormal potassium balance and causes of abnormal balance. 6. Your first objective is to 1. List 3 renal mechanisms which maintain normal potassium concentration in body fluids. 2. List 4 factors which influence renal excretion of potassium. And 3. State 2 regulatory processes for potassium excretion by the kidney. 7. In the slide tape presentation, Regulation of Renal Potassium Excretion, we discussed 2 of the important aspects of normal potassium balance. 1. The distribution of potassium in the body, and 2. The maintenance of normal levels of total body potassium by the kidney. 8. 98% of total body potassium is inside cells. Changes in plasma concentration usually, but not always, reflect changes in total amount. 9. Since the kidney is the main route of potassium excretion, constant total body potassium depends on renal function. 10. Potassium is maintained at normal concentration by the renal mechanisms of 1. Filtration, 2. Reabsorption, and 3. Secretion. 11. Renal excretion of potassium is influenced by 1. Total body potassium, 2. Sodium reabsorption and excretion, 3. Aldosterone, and 4. Acid-base balance. 12. Potassium excretion is regulated by 1. Transport of potassium across cells of the distal tubules and collecting ducts, and 2. The volume flow rate in the tubular lumen. 13. Remember to stop the tape to answer questions and to check your answers. 14. 15. In this presentation, we will discuss disorders of potassium balance. We will first consider the clinical manifestations of deficiencies or excesses of potassium which lead to the discovery of an abnormality. Then we will consider the pathogenesis of the abnormality, knowledge of which will assist in planning treatment and eventually correcting the disturbance. 16. Your second objective is to 1. List normal and abnormal serum or plasma potassium values. 2. List 2 artifacts which result in abnormal plasma potassium values that do not reflect abnormal potassium balance. 3. List 3 situations in which potassium shifts into and out of the extracellular fluid compartment while total body potassium remains normal. 17. Remember that normal plasma potassium is between 3.5 to 5 milliequivalents per liter. Hypokalemia is present if the plasma potassium concentration is below 3.5 milliequivalents per liter, and is severe if the concentration is below 2 milliequivalents per liter. Hyperkalemia is indicated by concentrations above 5 milliequivalents per liter, is severe if the values are between 7 and 8, and may be fatal if concentrations exceed 9 to 10 milliequivalents per liter. Plasma potassium above 7 milliequivalents per liter is dangerous and demands immediate attention. 18. In the case of potassium depletion, which may be indicated by hypokalemia, information about renal potassium excretion can help decide whether the abnormal losses of potassium occurred via the kidneys or whether non-renal routes are involved. If potassium intake is low, the excretion of more than 30 milliequivalents per day in the urine suggests that renal losses caused the potassium depletion. The excretion of less than 15 milliequivalents per day indicates that renal conservation is normal and that non-renal losses must be considered. 19. In the case of potassium excess, which may be indicated by hyperkalemia, a failure of renal potassium excretion is usually involved. 20. Laboratory reports of abnormal potassium values do not necessarily indicate the presence of a disturbance. The reported abnormality may be due to an artifact in measurement. For example, low serum or plasma potassium values can be due to an error in dilution made during the measuring procedure. 21. The indicated abnormality may also be an artifact due to the method of collection or handling. High potassium values are found with 1. Prolonged stasis due to venous obstruction by a tourniquet, 2. Hemolysis of red cells, and 3, less commonly, with certain hematologic diseases with high numbers of white cells or platelets which can release potassium. 22. In addition to problems in measurement and collection, abnormal serum or plasma concentrations may reflect a shift of potassium into or out of the intracellular fluid compartment, rather than a deficiency or excess. For example, changes in plasma potassium do not reflect parallel changes in total body content in 1. Disturbances of acid-base balance, 2. Familial periodic paralysis, and 3. Diabetes mellitus. 23. Total body potassium remains unchanged in systemic alkalosis. In this instance, potassium shifts from the extracellular fluid compartment into cells. In the presence of acidosis, potassium shifts from cells into the extracellular fluid compartment. Thus, knowledge of the hydrogen ion concentration of blood and the presence of an acid-base disorder is necessary to interpret the meaning of an abnormal value for plasma potassium. 24. In the rare condition familial periodic paralysis, both hyperkalemia and hypokalemia have been described. In these instances, transient shifts of potassium into and out of cells can cause abnormal plasma values without changes in total body potassium. 25. Also, insulin permits cells to take up potassium along with glucose. Because of the effect of insulin on cell membrane, plasma potassium may be high if insulin is deficient and may suddenly decrease when insulin is administered to a patient. However, total body potassium remains constant. 26. 27. 28. Our third objective is to associate manifestations of potassium deficiency and excess with the following elements of the clinical examination. 1. Patient's history. 2. Physical examination. 3. Electrocardiogram. 4. Clinical chemistry laboratory measurement. 29. A deficiency due to loss of potassium or an excess due to gain of potassium must be considered if abnormal plasma potassium values are not clearly due to an artifact of blood sampling or to shifts of potassium between extracellular and intracellular fluid compartments. 30. The patient's history will reveal details about the individual's potassium intake. It is important to recognize that changes in dietary intake alone are rarely responsible for potassium deficiency or excess. Changes in potassium intake can, of course, magnify a problem caused by abnormal losses or retention. For instance, a diet that is too low in meat, fruit, vegetables, and dairy products may contribute to the potassium depletion. 31. Clinical manifestations of abnormal potassium balance will be evident in results of physical examination, electrocardiogram, and measurement of urinary potassium. 32. In the case of hypokalemia, physical examination will show that all types of muscle, skeletal, smooth, and cardiac, are compromised. For example, if plasma potassium is below 2 milliequivalents per liter, severe weakness or paralysis of respiratory muscles may result. Severely reduced GI motility can be seen. Hypotension and cardiac arrhythmias, especially in the presence of digitalis, may occur. 33. In hypokalemia, the electrocardiogram characteristically shows sagging of the ST segment, flattening of the T wave, and more prominent U waves. 34. In the case of hyperkalemia, neuromuscular problems also occur. However, it is more likely that cardiac arrhythmias or cardiac arrest may occur first. T-wave changes in the electrocardiogram usually precede the occurrence of rhythm disturbances and may be the first indication of abnormal potassium balance. Immediate steps must be taken to prevent cardiac arrest if plasma potassium is above 7.5 milliequivalents per liter. 35. In hyperkalemia, the electrocardiogram characteristically shows flattening of the P wave, widening of the QRS complex, and peaking of the T wave. 36. Since the kidney is the major normal route for potassium excretion, it is helpful to learn something about the renal excretion of potassium by having the clinical chemistry laboratory measure the potassium in a 24-hour collection of urine. Renal excretion greater than 30 milliequivalents per day associated with hypokalemia suggests renal potassium losses as the cause of potassium depletion. 37. If potassium depletion has been present for several weeks, renal function, especially the ability to produce a concentrated urine, may be affected. This is manifested in frequent urination and excessive thirst. Thus, potassium depletion can be the cause of impaired renal function. 38. Conversely, impaired renal excretion of potassium can be the cause of potassium excess. This will be discussed after we consider the mechanisms involved in potassium depletion. 39. 40. 41. 42. 43. As part of your fourth and last objective, given a list of 4 renal causes and 1 non-renal cause which result in potassium deficiency, you should be able to state the mechanism of each. 44. In the case of potassium deficiency, assume that the deficiency is not severe and that we have time to consider the reason for the abnormality. Causes for abnormal renal excretion of potassium may be grouped into 4 categories: adrenal hormones, diuretic drugs, acid-base disturbances, and diseases affecting tubule function. A non-renal cause, loss from the GI tract, also affects potassium balance. 45. A diet very low in potassium may contribute to the disordered balance. However, this is not likely to be the sole cause. If obvious starvation is not evident, it is likely that depletion is due to an abnormal loss of potassium. Potassium is lost either into the urine, evident as a daily excretion greater than 30 milliequivalents per day, or from the GI tract. 46. The first cause of renal potassium wasting is the adrenal mineralocorticoid hormone aldosterone, which stimulates the secretory transport of potassium by the distal nephron. We will mention 4 possible conditions that result in high circulating levels of compounds with aldosterone-like activity, and that may be the underlying reason for continued inappropriate losses leading to potassium deficiency. 47. First, primary hyperaldosteronism associated with hyperplasia or adenomas of the adrenal cortex. 48. Second, hyperaldosteronism associated with increased production of renin and angiotensin secondary to congestive heart failure, hepatic cirrhosis, nephrotic syndrome, malignant hypertension, tumors, or rarely to hyperplasia of the juxtaglomerular cells of the kidney. 49. Third, Cushing's syndrome, due either 1. to therapeutic administration of adrenal steroid hormones, or 2. to overproduction of cortisol by the adrenal gland. Although not as potent a stimulator of potassium secretion as aldosterone, cortisol and other glucocorticoids do have some mineralocorticoid activity. 50. Fourth, we can also mention eating too much of some types of licorice candy which contains glyceretinic acid, a steroid-like compound having mineralocorticoid activity. 51. A second and very common cause of renal potassium wasting is the administration of diuretic drugs. Diuretics that act in the loop of Henle, such as furosemide and ethocrinic acid, and in the distal tubule, such as chlorothiazide, increase the excretion not only of sodium and chloride, but of potassium as well. The increased delivery of fluid to the late distal tubule and collecting duct caused by these drugs stimulates potassium secretion. Small daily losses of potassium, if continued over a long period of time, lead to severe potassium deficiency. 52. A third cause of renal losses of potassium is a disturbance in acid-base balance which results in alkalosis. Hyperventilation produces respiratory alkalosis. Prolonged vomiting or gastric drainage produces metabolic alkalosis. Recall that in alkalosis, the plasma potassium concentration is low, partly because of a shift of potassium into cells. However, it can be shown experimentally that high concentrations of bicarbonate in blood, as seen in metabolic alkalosis, also lead to increased secretion of potassium by renal distal tubules, and therefore to increased loss from the body. 53. The fourth cause of losses of potassium may be associated with some diseases affecting the kidney, such as chronic interstitial nephritis, renal tubular acidosis, and diabetes mellitus. 54. In diabetes mellitus, glucose acts as an osmotic diuretic. Severe hyperglycemia leads to a high concentration of glucose in tubule fluid, which increases the volume of fluid flowing through the distal tubule. Consequently, the losses of potassium may be severe. However, since metabolic acidosis may also be present in diabetes mellitus, the plasma potassium concentration may not be lowered as much as expected. 55. Finally, a fifth cause, which is non-renal, can result in potassium loss. As noted earlier, the gastrointestinal tract is implicated when potassium deficiency is present in a person who is excreting less than 15 milliequivalents per day in the urine. Gastrointestinal losses may be from the upper or lower ends of the alimentary canal. 56. Potassium, in addition to acid, is lost as a result of vomiting or gastric drainage. Since the concentration of potassium in gastric juice is only 10 to 15 milliequivalents per liter, volumes must be large to affect a serious deficit. 57. The concentration of potassium in diarrheal fluid may be 50 to 60 milliequivalents per liter, and disturbances of the lower GI tract may rapidly lead to potassium depletion. A number of disorders, such as viral enteritis, malabsorption syndromes, and villus adenoma of the colon, may be involved. The overuse of laxatives may also be a cause of potassium loss. 58. 59. 60. As Part 2 of your last objective, when given a list of 4 renal causes and 1 non-renal cause which result in potassium excess, you should be able to state the mechanism of each. 61. In the case of potassium excess, which may be indicated by hyperkalemia, if some unusual source of potassium is not evident, potassium retention is almost always due to an impairment in the ability of the kidney to excrete potassium. An exception to this rule would be if potassium were inadvertently administered too rapidly in an intravenous infusion. 62. The same 4 categories that were mentioned as causing excessive renal excretion can be used for convenience to subdivide the causes of abnormally low renal excretion: adrenal hormones, diuretic drugs, acidosis, and renal diseases. Non-renal causes of high potassium values will also be discussed. 63. The first cause of renal potassium retention is a deficiency of aldosterone. A normal amount of mineralocorticoid hormone appears to be necessary to sustain normal rates of renal potassium excretion. A deficiency of circulating aldosterone may be due to adrenal damage, as in Addison's disease, or to a low production of renin and angiotensin, as in some chronic kidney diseases. 64. The second cause of renal potassium retention is pharmacological and is due to 3 drugs which are potassium-retaining diuretics. They are weaker than furosemide, ethacrynic acid, and the thiazides, and have a more distal site of action. They reduce the rate of distal potassium secretion, but in different ways. Spironolactone inhibits the action of aldosterone on the distal tubule. Triamterene and amiloride interfere in an as yet unexplained way with the potassium secretory transport mechanisms. 65. The third cause of renal retention of potassium is a disturbed acid-base balance. One might expect, since alkalosis stimulates potassium excretion, that acidosis would lead to potassium retention. Experimentally produced respiratory and metabolic acidosis of short duration do reduce potassium excretion. However, if the acidosis persists for several hours or days, other factors complicate the picture. Actually, in some stages of prolonged acidosis, renal potassium secretion may be increased. So actually, acidosis is not an important cause of potassium excess. 66. The fourth important cause of renal potassium retention is diseases of the kidney. These impair the ability of the distal nephron to secrete potassium, either because of damage to the epithelial cells or because of reduced volume flow through the distal tubule. Hyperkalemia may be an emergency problem in acute renal failure with cessation of urine flow. Severe chronic renal disease may eventually lead to an inability to excrete sufficient amounts of potassium, but usually only after the glomerular filtration rate is reduced to about 5% of normal. 67. A fifth non-renal cause contributes to elevated plasma potassium. Extensive injury to muscle cells or hemolysis of red blood cells releases potassium into the plasma. 68. 69. 70. In summary, disturbances of potassium balance can be detected because of their clinical manifestations, symptoms, signs, and laboratory findings. Once the presence of potassium deficiency or excess has been recognized, an understanding of the underlying cause for the imbalance provides the basis for intelligent decisions about treatment. 71. This concludes the discussion of disorders of potassium balance. Refer to your study guide for the post-test and references for additional reading.